Alright, hello everyone. Hey, this is Joe Minardi, and I'm here to introduce you, get you all started on a little bit of what I hope is some fun stuff for you about ultrasound and what we're looking to do with the third year clerkships. And the whole goal of this is to first talk to you about why we're doing this, what we're going to do, and give you a little bit of introduction into how ultrasound works, how to get images, and how, even as a novice, how you can help our students learn a little bit about ultrasound and incorporate this technology into their practice. So that's exactly what we're going to go through. We're going to do why are we doing it. We're going to talk a little bit about just the basics of how ultrasound works, how to get images, and then I'm going to try to allay some fears and talk about how you can help students even as a novice. And I'll speak from experience. When I first was asked, hey, why don't you teach ultrasound to our EM residents? I was a novice. I could barely turn the machine on and find like a 25-week baby. But eventually with some practice and a little bit of help, even as a novice, I was able to help improve what our residents could do. And then, of course, I gained some momentum, learned more, and came to really believe ultrasound was a pretty awesome tool and that it really does help me, be a better doctor, take better care of patients. So it's lots of fun, and I hope that you'll find it the same as I do. So a little bit of why are we doing it, why ultrasound. First off, ultrasound is super safe. You all know this. There's no radiation involved for most of what we do. There's no nephrotoxic contrast. It's very portable. It's repeatable. It's pretty cheap. You can take this into remote sub-Saharan Africa. You can take this down into Ritchie County, where I'm from, where there's nothing else much going on. It's really useful and helpful, and it's just awesome. And if that wasn't enough, study after study and more research time and again shows that clinicians using ultrasound at the bedside can make diagnoses more timely, make them more accurately, use fewer resources, fewer CT scans, fewer MRIs, fewer visits. And if that wasn't good enough, we can do our procedures more safely with real-time ultrasound guidance or static ultrasound guidance. And overall, better quality care, better use of resources when we take care of our patients. So what does ultrasound do? I want to make sure that nobody thinks ultrasound is a replacement for a careful, detailed history and physical exam. It's not. In fact, you need a good history and physical exam to help the ultrasound be meaningful and useful. And I even think that learning ultrasound improves your physical exam because you get that immediate feedback of, wow, the liver felt big, let me look at it and measure it, and wow, yeah, I was right, or no, I was wrong, how did I miss that, what did I do? There are some studies suggesting that, but more about that later. And another thing that's really cool about ultrasound is it actually keeps you at the bedside another minute or two. Not a long time, and we'll talk about how you can prevent it from being overly long, but you are usually at the bedside another extra minute or two, and with that time, you're getting more face time with the patient. Sometimes I'll sit down to do the ultrasound, which they like, and sometimes they'll throw in some other historical things, or you'll build better rapport, and so they'll be more compliant with your plan of care, and it segregates you less from the patient. Instead of saying, here, I'm going to order this test, and then I'll see you back in a couple hours or a couple days or a couple weeks. You've done your ultrasound right there at the bedside. You've shown them some anatomy, maybe given them a diagnosis or ruled out a diagnosis pretty immediately, and patients really like that. And it actually, I find it to make my clinical work even more rewarding than before when I didn't really know how to use ultrasound. And this is a saying from some of my ultrasound colleagues that making horrible doctors decent and good doctors great. And I can say that this is definitely true for me. Like I said, when I first graduated residency, I wasn't terribly good at ultrasound, and I didn't even really believe in ultrasound. I thought it was kind of a fad that needed to go away, and I hate to admit that now because I've definitely been proven wrong. This tool's awesome. It just, like I said, better diagnoses, quicker diagnoses, better differential diagnoses, better procedures. Pretty much every aspect about it makes you a better doctor, in my opinion. And then just other reasons, some people will compare ultrasound to a stethoscope, but that's kind of selling ultrasound pretty short, I think, because you can apply ultrasound to pretty much every organ system, and it has application for almost every medical specialty in some degree. And if you didn't know it, a lot of our residencies now that we're training our students for have some requirements related to ultrasound within them. And here's just a list of some of them. There's probably more than this, but these are some of the most common ones that have well-established ACGME ultrasound requirements within their resident training programs, and we owe it to our students to make sure they're ready for this and also ready for incorporating it more into their practice and making it part of the future of medicine. And so why is this getting more momentum now? Well, ultrasound has gotten smaller, cheaper, it's way easier to use, so that now even these handheld machines that you can carry around in your pocket can give you pretty nice images and you can take these to the patient instead of waiting for the patient to go to some special room or suite where there's an ultrasound. You can take it next door, and you don't have to be a rocket surgeon or anything like that to learn how to do this. Anybody can do this. And of course, there's more scrutiny on ionizing radiation, how we probably need to decrease some of that. And our whole, at least in the States, our reimbursement models are moving more from a quantity model, which we've done in the past, to more of a quality model. And ultrasound is a tool, again, that it's cheap. It can make our use of resources more efficient, make our procedures safer. All these things improve patient quality, patient care, and will probably ultimately reward us when it comes to reimbursement. Not that we should care that much about that. And again, why now? So I just want to point out this isn't a new thing. Emergency physicians have been using ultrasound for a couple of decades now, and cardiologists and sonographers and vascular surgeons even longer than that. But applying it to pretty much every body system, that's something that we've been on emergency medicine for a couple of decades now. And we're at the point now where multiple medical schools are starting to incorporate this into their curricula. We're lucky to still be kind of the first wave of medical schools, but we're not the first. And this is an area where we're not just training students and residents to do what we want to do now, but we're training them to be ready so that they're ready for the future of medicine, and they don't have to go and learn this in CME courses when they're already busy in their clinical practices, and it's a lot harder to learn. I think getting students while they're in medical school, making this part of their training, is definitely the way to go. And 20 years from now, when I'm a patient, I'm definitely going to see some of the dividends of some of the work that we're trying to do now. And then just, this is something that's widespread in other countries, in Europe, and places that aren't saturated with CTs and MRIs. Ultrasound is already a standard bedside tool. We're actually kind of behind some of these countries, but luckily we're learning from them, trying to catch up. And again, other medical schools are already doing this, and a lot of residency programs already have ultrasound requirements, and we're trying to get our students so that keep them ready. And of course, WVU, I'm going to throw out my biased opinion, of course. Being a WVU graduate, I see us as leaders in medical education. We're very patient-focused. Our students are well prepared for their residencies, and we want to prepare our students to go out and serve the rural, underserved in our state to a large degree, and ultrasound is a great tool to do that. There's all kinds of papers about using ultrasound in austere environments where there's not a lot of other resources around, and how that can really make a big impact on patient care. You don't need me to tell you that West Virginia is almost an austere environment itself, and so ultrasound is a great tool to put in the hands of physicians that we want to go work and help some of these rural, underserved populations that we care for. And it's also always a nice thing to be kind of at the leading edge of medical education when you're recruiting students, and to make sure people know what you're doing nationally. We're luckily already now nationally recognized for some of our ultrasound curriculum that we've put into place, and I think that's pretty cool. Alright, so enough of my sales pitch, enough of me trying to show you why I think this is really cool and why ultrasound is an awesome tool. I want to get into a little bit about just how to do it, and how does it work, and make it so it's not so scary. It's not a scary machine with a bunch of buttons. In case I didn't mention this, I don't have any disclosures. Philips and Sonosite, none of them give me any money, unfortunately. Looking back in the past, a lot of our bedside diagnostic tools have been these things, right? We go in, we talk to the patient. The minute we walk in the room, generally we're already observing them. We're listening to what they say. We look at their nonverbal communication. Then we put our hands on them. Sometimes we smell them. Luckily, we don't usually taste them. But these are our most important diagnostic tools. And then, we throw in some of these. We carry these around in a black bag, or maybe they sit in the shelf at your house and you don't really ever use them anymore, like me, except when my kids are sick. These are some things. These are useful things, and I still use all of these just like you all do. They have their place, but they're somewhat limited. I mean, look at these things. This stick over here. This is, a stick with a rock on it. Flashlight. Needles, and the stethoscope's probably the most advanced thing on here, and that's 17th century technology. These are tools that are widely held in the tradition of medicine. They still have their place, but we have better tools now, like bedside ultrasound. And again, you can even carry around in your pocket, take it to your patients, and give you information that those tools and history and physical just can't give you. So again, I'm going to try to demystify some of this, make it less scary, and give you a little bit of foundation on just how it works, so that when you put your hands on it, it'll make some more sense. Just briefly, characteristics of clinical ultrasound and this point-of-care ultrasound that we're talking about, and how the approach and the mindset is a little bit different from what you might get in a radiology lab or a vascular lab or an echo lab. And what I'm going to say is, for the most part, clinical ultrasound, point-of-care ultrasound, is not going to replace the comprehensive studies that you're going to get in these other areas, but it's going to add to your history and physical, and sometimes it might replace some of those, but not very often, or it might help you get fewer CAT scans or whatever. But it doesn't necessarily replace those things. So if you're a radiologist or a cardiologist or a vascular surgeon or a sonographer, any of those fields, we're not putting you out of a job. Don't worry about that. We're expanding what we do with ultrasound. We're not taking away from what you guys do with ultrasound. So first off, this is a study that is performed and interpreted by the clinician at the bedside real time, which makes it fun, makes it rewarding for the patient, but also means that there are some different limitations and differences in the approach. It has to be quick, right? You can't add a 15-minute ultrasound on to your already 15 or 20-minute patient visit, so you have to do this quickly and be very focused on what you're doing. And like I said, it's giving you information that history and physical can't give you, okay? Diagnosing LVH by auscultation, to my knowledge, isn't that terribly accurate, but diagnosing it by bedside ultrasound can be done relatively quickly and relatively easily. And specific clinical questions, right? So this is another area where you save time by being focused. You're going to ask yourself specific, usually binary yes or no questions, and then incorporate that into the rest of your plan of workup and care. And one of the examples is there hydronephrosis, or it might be, is there a pericardial effusion? Are there gallstones? These are all yes or no questions that you should be able to pretty rapidly answer with your bedside study. So there was a congressional law passed that said if you're going to introduce people to ultrasound, you have to talk about physics. So I'm going to fulfill my congressional obligation and talk to you a little bit about physics, but mostly really about just how the machine works, so that I often compare this to riding a bike. I don't really care about the gear ratios of my bicycle or the tire pressures. I just care about being on the bike and enjoying scenery, hopefully. But you got to know how to ride the bike before you can enjoy the scenery. So I'm going to teach you how to ride the bike so that you can enjoy the anatomy of your patients, okay? So if I boil this down to one little slide of what you really need to know and what I want you to get out of this with physics and operating the machine is you need to be able to make sure you pick the right transducer for the job that you're trying to do. You need to get the machine on the right setting. So if you're looking at the abdomen, get the abdomen. If you're looking at the heart, choose cardiac or whatever. You need to adjust basically two buttons on the machine. There's a few other buttons I'll teach you about, but two things that you need to fairly regularly adjust, and that's your depth and your gain. Everything else is like an on button or an enter button, okay? So two buttons that you're going to adjust, depth and gain. I want to teach you a little bit about how to hold and manipulate the transducer. This is going to sound a little bit like teaching kindergarten finger painting, but what I've found is teaching people some of these minute details about holding the transducer helps them gain skills more quickly, so I'll go over some of that stuff. And then you got to be able to recognize anatomy, and there's a few artifacts I'll teach you about. The great thing about most of the anatomy we're going to talk about is once you get images of it, it just looks like black and white pictures of the anatomy that you already know, okay? So it's not that terribly difficult most of the time. So physics, this is Galileo. He's the father of modern physics, and usually it's the obligatory Einstein or whatever, but I like Galileo. So ultrasound is just sound. It's in a higher frequency than we can hear, and usually from most of the ranges we're going to talk about using are somewhere around 2 to 12, maybe 15 or even 20 megahertz. But it's just sound. Sound is energy that travels through a medium and can bounce around on and off of tissues. Now the transducer, this is something you have to know a little bit about how it works. So ultrasound, again, are longitudinal waves that travel through a medium. You don't need to remember that. I'm just telling you that because it's important physics stuff. This is important. The sound waves are generated by little crystals inside the transducer, an effect called the piezo or piezoelectric effect. Now, I don't care about the piezoelectric effect, I just care about the anatomy, but it is important to know that those crystals are the brains of the ultrasound, and they're the most expensive part of the whole ultrasound system. So it's good to take care of your transducers, don't clean them with acid, don't step on them, don't throw them at people, take care of your transducers, don't break them. So the ultrasound goes into tissue, it bounces off of molecules and tissue planes and then bounces back to the transducer where it's then translated into a visual display. And that's pretty much it. That's all of physics in a nutshell. The rest of what we're going to do is how to work the machine. So, working the machine. Like I said, one of the first things you need to know how to do is pick the right transducer for the job. Now, the way I think about transducers are, there's high frequency and low frequency, okay? High frequency transducers give you high resolution. So you can remember that, high frequency, high resolution. The cost of that resolution is they don't penetrate very far into tissue. So high frequency transducers are usually what you use when you're looking at superficial things. Low frequency transducers give you lower resolution, so low frequency, low resolution, but they allow you to penetrate into tissues more deeply, Okay, so if you're looking at something deeper in the abdomen or the heart, you're going to usually use a lower frequency transducer. So just some examples: high frequency, again, think superficial stuff, so like vascular access. So if you guys are doing ultrasound guided central lines already, you're using high frequency transducers. Superficial or peripheral nerve blocks, superficial skin abscesses, musculoskeletal things, looking at joints or tendons that are near the skin, all superficial stuff, all high frequency transducers. Lower frequency, and that's, if you're looking at the heart, looking at things inside the abdomen, the gallbladder, the aorta, looking at deeper structures in the chest, that's all things you're going to use low frequency for. There's ranges, but think about 2 to 5 for the abdomen and the chest, and think about maybe 8 to 15 for more superficial things in the extremities. Alright, the ultrasound machine, a little bit. Now, what I'm going to tell you about the machine is, if you have one of these machines with a ton of buttons on it, you can ignore most of them. Now, there are newer machines and point-of-care specific machines that have fewer buttons, but it doesn't matter. There's mostly 3, 6 maybe buttons that you need to know, and the rest you can ignore, okay? So the buttons you need to know, now listen to how easy these are. The first one is the on button. Alright, so if you're going to count that as a button, you know, there you go, the on button. Find it, figure it out, get the machine on. Then there's a button that helps you select the probe. Now sometimes you may have to attach the probe manually, but most of the machines that we use have a selection where you can just select one of the probably 3 probes that are hooked up. And these GE machines that we use in our lab a lot, it's, down in here somewhere, you can select the right probe for the job. And then there's a preset button, and this machine is actually the same button, probe preset. And that's where you just, again, you're going to select your preset. Now you're going to ask me, how do you select these things? How do you work this? It's kind of like your old Dell laptop where we've got some kind of trackball or a mouse pad in most cases, and then we have our mouse key or our enter key, which we also call the set key. And that's just like your select key on the mouse, it's your enter key, it's your kind of your master key is the set key. And that's usually somewhere around the trackball. It seems like it's never on this intuitive side that it should be, but it's somewhere around here, okay? So those are all pretty easy things, right? Getting the machine on, the probe, the preset, and then your master set key. Those are all very, very basic. There's 2 buttons that you really have to know how to work a little bit and manipulate, and they're pretty easy too. So there's a depth key or switch or toggle, and on these machines it's right over here, and it's a knob. You turn it one way counterclockwise to decrease the depth, turn it clockwise to increase the depth. But that's going to be important, and that's something you have to adjust fairly regularly when you're doing ultrasound. And there's the gain. The gain is just the overall brightness of the image on your screen. It's like turning up the volume on your stereo. When you turn the gain up, the volume or the intensity on your screen increases, so everything looks more white. As you turn the gain down, everything looks more black. Some machines these days have some type of auto gain or an optimized function, and so you can play around with that and see if you like it. Most of the time I find that adjusting the gain myself manually is more useful. So that's it. Get the machine on and get the right probes, and then after that it's 2 buttons, 2 switches that you really need to mess with at all. Okay, so next up, the ultrasound screen. And just important to kind of recognize some of the things that are on the screen, and so you can kind of get in the habit of a quick 2-second assessment of what you see on the screen. And after you've done this 5 times, it's second nature and you don't even think about it, but you have to know what you're looking at a little bit. So every machine has a little dot that is the indicator, and sometimes it's their logo or their advertisement, but every machine has this, okay? Every screen is going to show you the indicator. Now this indicator on the screen corresponds with something on your probe that you can usually feel, okay? And so that directs you to how you're oriented on the patient's body. So if you have your transducer indicator directed towards the patient's head, then on your screen, their head should be on the same side as the indicator. So if the indicator here is towards the patient's head, then their head is up here, meaning their feet are here, and this would be more superficial stuff and deeper stuff. In this case, we're looking at someone's spine, so head here, feet here, superficial skin of the back, and deeper tissues of the spine. And that can change depending on the plane. So if I direct my indicator towards the patient's right, then this becomes the patient's right, this becomes their left, this becomes anterior, and this is posterior if we're on the front part of their body. And then you're going to have the probe. The probes sometimes have names, but honestly I don't look at this very much, because usually if I just look at this, the shape of this footprint should match the surface or the footprint of your probe, that'll tell you which probe you have hooked up. You don't need to look at this. So I can tell here this is a curvilinear surface, so this must be a wide curvilinear probe. And but if you're not sure, you can look for the name of the probe somewhere on the screen. And then the preset, I do look at this frequently to make sure I'm in the preset that I want. And here, this one obviously makes sense. We're looking at someone's spine, and we're in a spine preset, so that's good. Sometimes if you're having trouble, you'll realize, oh, I'm trying to look at the heart, and I'm in the metacarpal presetting or something like that, and that'll just help you troubleshoot if you're having problems. So check that out. Make sure it kind of fits what you're looking at. The frequency, again, this is something you can look at. Sometimes you can adjust this slightly. Even a 4 megahertz probe usually has a range from maybe 3 to 5. Sometimes you can adjust this, or at least just make sure that, hey, I'm looking at something deep. My frequency is low. That's what I want. The depth, this is something I do look at fairly frequently, the maximum depth on our screen, and you can adjust this, and you can also see these centimeter markers that are lined up here. That's important to know if sometimes things don't look right, or you're cutting off a structure at the bottom of the screen, or your interesting structure is all squished up here at the top. You can adjust your depth and make that image look better, and that'll make more sense to you when you're looking at it. And then lastly, again, are these centimeter markers on the screen that show you your maximum depth and help you roughly kind of guesstimate the size of different pieces of anatomy or lesions that you might see. Alright, so that's it for the screen. I'm going to briefly talk to you a little bit about some of the ultrasound modes. These aren't super terribly important as you're beginning, but our students know these already, and so it's good for you to know these because you will use these sometimes, and so it's just good to understand them a little bit. So B mode is the most important mode. This is what you use for almost everything. B stands for brightness, and what that means is the intensity of our reflected sound is represented as differing brightnesses of the dots on the screen. So things that reflect sound very intensely give you a bright white signal. Things that reflect sound less intensely give you a darker signal. And lots of things are in between. So in this example, this is a heart, this is a left ventricle here. The pericardium is a very intense reflector of sound, so you get a very bright white appearance of the pericardium. The blood within the left ventricle doesn't reflect sound very intently, so it appears black, and that's what you see on your screen. This is also called 2D because it gives you a two-dimensional image of your anatomy, or sometimes called grayscale ultrasound. Those are all the same thing. It's all B mode, and often it's a letter B on the button that selects this mode. Now that's the one you need for 90% of what you're going to do. These other ones are used less frequently, but you will use them often enough that you should at least be familiar with them. M mode, M stands for motion, and what M mode is a mode that allows you to place a spike down across your screen. You can move this to different places, and then analyze ultrasound information that's gathered along this singular line, and then graph that over time, and it gives you resolution for moving structures that you can't get on this wider image. Okay, so here's this spike. Its max depth is 20 centimeters, so this should be 20 centimeters, and then the x-axis here is time, and so we're graphing motion over time. And you'll commonly use this in things that are moving quickly, like the heart or the fetal heart. Those are the areas where you use this most commonly. Otherwise, you don't really use it a lot for other things. But that's M mode. And then color mode, you will use this on occasion. Sometimes it's called color Doppler or color flow. You've probably seen this before, but just to recognize what it is. So with color flow, you're able to place a sample box into an area on the screen, and you can usually move this to different areas. You can size it differently and analyze. Usually what you're analyzing is blood flow. And this gives you information about direction and velocity of flow, okay? Rough information, not detailed information. Gives you a visual display. So I put this box here, and I have blood flow that is moving both towards and then away from our transducer, and that's what the colors mean. The colors indicate direction. They have nothing to do with arterial versus venous. And the direction is generally. So I'm looking at the left ventricle here, and the left atrium is here. Blood is coming into the left ventricle from the left atrium, and so that direction is generally towards our transducer, which would be up here. So that blood flow looks to be red. So we have red coming into the left ventricle, and then the blood going out of the left ventricle out through the aortic outflow tract looks blue because it's moving generally away from our transducer. So red comes in towards the transducer, blue goes out away from the transducer. And that's what this little mnemonic BART means: blue away, red towards. And that's what this scale means: red towards the transducer, blue going away. And if you're not sure, you can look at the scale to double check that. And you can also look at where the colors are on this scale to make rough estimates about velocities. But if you want specific velocity information, this scale and color is not what's really going to tell you that. So that's color Doppler. Next up is Spectral Doppler, or sometimes just called Doppler or pulsed wave Doppler. Sometimes the button on the machine will be PW instead of Doppler or D. There's another form of Doppler that we use sometimes called continuous wave Doppler, but we're not going to use that very much. What this does is, again, you have a little sample gate. Now it's much smaller between these two calipers, and you put these wherever you're interested to analyze, usually again, blood flow. And you get very specific information about velocity and direction of flow in this small area, and it's again graphed over time. And this line across the machine is the zero line, and anything above the line is flow towards your transducer, below the line is flow away from your transducer, and again you have a velocity scale. This is positive 40 centimeters per second and negative 40 centimeters per second. And so here what we have is we're looking at someone's popliteal vein. You can see there's not a lot of flow. There's a little bit of flow away from our transducer here. It's very low velocity. And then here someone squeezed on their calf, and so that blood rushed up through that vessel, and we got high velocity flow there for a second in that vessel, and we can see that on our Doppler display. And with this you also hear an auditory feedback, and again you get this graphical display. For most of what we're going to use and talk about using color and spectral Doppler for is all very qualitative. Most of the time we're not super interested in the direction of the flow or even the exact velocities of the flow. Most of the time we're just looking to see, is there flow, yes or no? Is it look to be arterial or venous, yes or no? Most of the time those are the questions we're going to be trying to answer anywhere outside the realms of the echo lab or the vascular lab. Alright, that's enough about the physics and the machine. I just want to go a little bit through what some of the kind of characteristics of ultrasound images and some of the terminology, so you understand, when we're talking about using words like hyperechoic or echogenic, what we're talking about. So this is a word that's thrown around a lot. You'll hear this a lot, this term of echogenicity. We'll say things are hyperechoic, and when we say that, what we mean are things that are sonodense or intense reflectors of sound will appear hyperechoic or more white. Okay, so this is an example of something that's hyperechoic, and things that are less intense reflectors will appear to be hypoechoic or sonolucent or more black. So this structure is hypoechoic compared to the surrounding tissues. This structure is barely visible as isoechoic, or about the same echogenicity as the surrounding tissues, and you could call this anechoic because there are almost no echoes or no reflections within it, or you just call it very hypoechoic if you wanted to. Just some examples of what we mean by that. So this is a couple of examples of a kidney, and the outside part of the kidney here is the renal cortex, and then this brighter white tissue in here is the tissue of the renal pelvis. This renal pelvis is dilated with hypoechoic urine, so that would be a good example of hypoechoic or almost anechoic fluid in the renal pelvis. And in this example, again, we've got kidney here, and what we see here is a very intense bright white stone right in this renal pelvis that I would describe as hyperechoic or very echogenic. And we can also see an acoustic shadow here. We'll get to that later. So that's some good examples of echogenicity in action. You're going to hear this term thrown around some, this term of an acoustic window. When we talk about an acoustic window, what we're talking about is something that propagates sound very well, and we use it to help us look into another structure that we want to see. So I think the example makes it make more sense. This is a full bladder in a female patient, and we're trying to look at the uterus back here. And because the sound propagates very well through this fluid in the bladder, that gives us better images of our uterus behind it. If this bladder was empty, we would have a less optimized image of this uterus. It wouldn't look quite as good. So we're using the bladder as an acoustic window because it propagates sound well to help us see structures behind. And same example over here, we're using the liver shooting through the abdomen, and the liver to help give us, again, because the liver is mostly fluid density in normal people, and so the sound is propagated very well through that and gives us more detailed and more resolved images of the heart. So those are acoustic windows. A couple of artifacts that are important for you to know, just again so you recognize them, so you see them on the screen. The most important one by far is shadow artifact. And this is just when the sound energy comes down from the transducer and strikes something and it can't go through it. It bounces off, and so no sound comes through, and that casts a shadow. Just like the sunlight casts a shadow when it strikes my body, The ultrasound, when it strikes this thing that it can't go through, casts an acoustic shadow when it sees these gallstones right here. And sometimes these can help you because these shadows might help you identify these gallstones or help you figure out where they are. And in other cases, like this down below, these shadows from the ribs crisscross over top of this kidney here and make it a little bit harder to identify, and the image of the kidney is not very good. So sometimes shadows hurt you, sometimes they can help you, like up here. We also see back here, this is the spine, and these bones also cast an acoustic shadow, so that helps us identify the spine in that case. So very important artifact. You've got to know it and got to recognize it. This artifact doesn't come up as much as shadow, but it's important not to confuse with regular shadows. It's edge artifact, or sometimes called edge shadows. Now this is an artifact that occurs when the sound strikes a curved structure and some of the ultrasound energy gets bent or twisted around it, causing these edge artifact or edge shadows. The way you can tell this apart from regular shadows is edge artifact shadows will always stay on the edge of the structure no matter how you scan through it. You'll see them follow the edges. Whereas when you scan through a gallbladder with a gallstone, as you scan through, you'll see the gallstone in the shadow, and as you scan past the gallstone, the shadow will disappear. So that's how you can tell these apart. Another important artifact, probably the last one I think, is Reverberation Artifact. You'll often see this when we see another very intense ultrasound reflector. It's kind of the opposite of a shadow because you get this bright white reverberation artifact that goes down. So in this case we have a needle here, and what's happening is the ultrasound beam gets bounced back and forth multiple times across here at different time periods, and so the machine interprets that as something all the way down at a farther distance all the way across the screen. That's what it shows here. And here we see this wire in a vessel that's been cannulated, and we see all these reverberation artifacts down from the wire. A common artifact, and again sometimes it is a helpful artifact that helps us identify structures or like foreign bodies in tissue.